Why don't we get started? Thank you again for joining us. My name is Ana Lucia Cordova. I'm the Director of Strategic Initiatives and Research Funding at the Office of Research here at UC Davis. This is our team research forum. It's a forum we run kind of bi-weekly, sometimes once a month, where we try to identify new programs or research areas on campus that appeal to a broad range of disciplines and people on campus, and we try to foster an informal conversation, an exchange of ideas. So today we partner with our colleagues at Venture Catalyst to have a conversation about innovations at the intersection of climate and health. I'm going to pass it on to my good friend and colleague, Janine Francis Elliott. She's the interim director of Venture Catalyst. And I just want to acknowledge that we also have in the audience Belen Flores, who is the program manager for the ACE program. And I'm going to let them take it away. Please remember to mute your microphones and enjoy our session.
Good morning, everybody. So glad to have you here. My name again is Janine Elliott, Interim Director for Venture Catalyst. And part of the inspiration for having this session today was really about embracing the fact that UC Davis is such an interdisciplinary institution. And when we think about climate change, there's so many different facets of what innovation and entrepreneurship, intrapreneurship, and so on can look like in this space. And so I want to provide just a little bit more context for today's session, and then we'll get a chance to jump right in. So I'm going to just pull up my slides here real quick. And putting together this session was a really interesting adventure because of actually a conversation that transpired with one of our speakers today, Kei Nakagawa, in talking about that intersection of healthcare, health outcomes, and how that relates to climate change and global warming. So for context, UC Davis was a recipient for a California Climate Action Grant, and Venture Catalyst was one of the recipients for grants specific to how innovation and entrepreneurship could be used to basically get innovations off the shelf or off the pages of your computer and out into the world. And so we started an initiative called ACE, Aggies for Climate Equity, or Aggies for Climate Action and Equity, as I should say. And this is really about getting that translational research going, getting the community talking to one another, and doing so in alignment with California's climate adaptation strategy, which is really looking at how we can mitigate greenhouse gas emissions in the first place through initiatives like energy efficiency, carbon emissions reductions, and so on. Adaptation, so recognizing that climate change is already here, how can we adapt to a changing climate? And then resilience, because those climate disasters are certainly becoming more and more frequent and aggressive. So the ACE initiative is doing this in a couple different ways. So we have a proof of concept grants program. We're excited to say that the awardees will be announced very soon. And so I see a couple familiar faces on the call today who applied for the grants. We explicitly tried to pick people for today's session who did not apply for the grants, just to avoid any sense of favoritism. We're excited to have today's research forum, where the goal here is really to give you a chance as attendees to learn new things about different facets of the intersection between climate and health. And then actually at the OR Research Expo on April 18th, if this isn't already on your calendar, we'll be doing TED-style talks from the awardees of the climate grants. That's basically like a research forum like today, but featuring those awardees from the proof of concept grants. And that will also be a great opportunity to cross-pollinate and network with peers. For those of you who are interested in engaging more so with students, specifically at the intersection of your work, there are opportunities to be a judge for student climate change solutions competitions hosted between us and the Student Startup Center. And we're excited to say that we will be launching a course this fall called Hacking for Climate, where entities or folks like yourselves can put forward problem statements, and students will conduct different types of stakeholder analysis to come up with how that innovation could be replicable and scalable moving forward to multiple constituencies to have maximum impact. And then last but not least, Venture Catalyst. For those of you who don't know about Venture Catalyst, we are a group on campus that supports innovation and entrepreneurship. And it is really in service of our land grant mission of getting the innovations out of the halls of academia and out into the world. And in our case, mostly doing that through an entrepreneurial or, sort of multi-stakeholder dissemination lens. So we are here to support you. And my colleague, Belen Flores, I would love to just really give a shout out to her for being a part of making all of this happen both today and for the ACE initiative overall. So if you have questions about how to get involved, please do reach out to Belen. She's an amazing resource. So I would love to thank our speakers today for joining us. Today we're going to get a chance to hear from Kei Nakagawa. Kei joins us from UC Davis Health and holds multiple titles. I know him from being the director of the Digital CoLab over at UC Davis Health, looking at how the intersection of digital health, big data, information technology can improve healthcare delivery both within and beyond UC Davis Health. He also holds the titles you see here: the Director of Innovation at UC Davis Health, Executive Director of the Cloud Innovation Center, which I believe he's going to touch upon today. And then he is also a Vice Chair of the HIMSS Social Determinants of Health Committee, because as we all know, there are a lot of factors that impact health. And so this question of how environmental justice and social determinants affect health, I think, is one that's near and dear to Kei's heart. After talking with Kei and having his presentation, we'll get a chance to hear from Dr. Hernandez. He's been working on some really exciting technological advances around energy efficiency in imaging equipment with his background in medical physics and radiology. Basically developing ENERGY STAR standards that we think about for our microwaves or our refrigerators, but for the heavy medical and radiological equipment in hospitals that is extremely energy intensive. So just a really exciting way to think about how different worlds start to collide in these interdisciplinary spaces here at UC Davis. We're going to leave about 15-20 minutes at the end for Q&A and just discussion. We really want this to be a conversational forum. So we have a really great brain trust of attendees on today's call looking at these intersections between climate and health. So I know this is just one slice of that brain trust presenting today, and I'm really excited to see where the conversation goes. So just a quick housekeeping reminder: if you are an attendee, please go ahead and put your camera and stuff on mute, your microphone on mute, and I'm going to hand it on over to Kei. Come on down, Kei.
Great. I'll share my slides in a second, but thank you so much for having me. This is really an honor to talk about, I think, a very important topic where we really can't solve this alone. So being able to represent the health system side, but really seeing so many people that I've already had the pleasure of working with on the main campus side, and new names and faces, is so important, just because I think we at UC Davis are at such a great institution where we always put the mission front and center in what we do. And we're so interdisciplinary and collaborative as a culture, as expertise that we have, to be able to actually make a really big impact on climate and climate health. My first experience with climate was being an LA boy going to a college in upstate New York. And I remember the winters are like longer. It's like 2 seasons, right? Or maybe even 3. And there'd be so many days where, I'm looking out the window at like, I don't know, it's like 8 a.m. And I'm like, there's no freaking way that class is going to happen today. And so I'm in my bed, in my dorm, and I'm just like clicking the refresh button on my inbox, just like waiting for that email to come being like, class is canceled. And literally, that has never happened in my 4 years, even though there's been at least probably like 20, 30 days that I can, remember where it's like there's tons of snow and there's no way that you could even like walk to class. And yet, up in Ithaca, New York, they always found a way to make class happen. And it'd usually be like, 8:55, where I'm like, okay, this might actually happen. So you're like rushing to put your clothes on and walk into class. You fast forward to, I worked in DC. And you may have recalled that the government shut down due to Snowmageddon. And I'm looking out and I'm like, it's barely snowing. Like, I can't even believe the government's actually shutting down. It's like literally on one side, I remember classes not getting canceled. And then I'm like, the entire federal government is shutting down when there's like literally, not that much snow like happening. And I think part of the message here is, as Janine mentioned, like there's so many worlds colliding with climate health, but we really live in one world, right? We all share one climate, but we experience climate so differently based on where we live, what our background, our socioeconomic status, our education, our knowledge of science, like all these things actually make this one shared climate very different for the people, the locales, and the geographies that we live in. And I think that's so important to recognize. Our perception, our experience with climate really drives a lot of opportunities for us to collaborate, and also the importance for us to really think about this in a more personal way. And so I am now going to start sharing my screen here. Do you guys see my screen by any chance?
Yes.
Okay, perfect. So the title of my talk is really, climate, our biggest threat to health equity. I think there's a very big possibility that we're going to significantly exacerbate the health disparities that we see today. And, being at UC Davis Health as a medical student, and also in my current role, I'm actually really proud of having seen for over a decade how much UC Davis and UC Davis Health is so dedicated to reducing health disparities and tackling health equity in a from day one and throughout the history of our institution. And so I think we're again in a very important position to address this. I'll kind of talk a little bit about where I come from with the Digital CoLab, the Digital Health Innovation Hub, and the Cloud Innovation Center. But I want to talk about the role of our healthcare industry in the climate change and the climate health aspects, and talk about what we're doing at UC Davis Health to improve those kind of models of care that might actually be more climate friendly and reducing the carbon use of the health system, and then ultimately talk about climate health and medicine. So I want to kind of first share the strategic vision that our leader set. Dr. Lebarsky is on the right as our CEO. Dr. Ashish Atreja is our CIO and Chief Digital Health Officer. And again, I'm actually really proud that as an institution, when you read, our mission and our vision, the first words that you see on this mission here is grounded in equity. Everything that we do, being a health system that serves one of the most diverse patient populations in the country, also serving one of the most diverse geographic catchment areas of any health system in the country, we are very much, our directive is aligned with this mission of delivering equitable care. And I also love this concept of delivering tomorrow's healthcare today. We're always forward looking, saying, how is healthcare going to change, and how do we adapt to that today, to make sure that our patients are okay, and that we're actually doing the things that we need to protect our patients, and their healthcare. So a lot of my work is really centered around this vision and this mission, and specifically at the Digital Health Innovation Hub, we're trying to say, okay, well, what are the biggest health inequities that we can solve? And we're in a very unique time in healthcare where technology is really becoming integral and incorporated into so many aspects of the care that we're delivering. And our patients are starting to be so much more engaged with the healthcare and through that technology, whether it's an Apple Watch, Garmin, or other devices that are able to now send us information from the home. We have a lot more visibility beyond the four walls of the hospital or clinic, which can be really groundbreaking. And so we try to really look at this from how can digital health and digital technologies close the digital divide? How do we scale that care to really every part of our geographic catchment area, so that patients may not have to drive 2-3 hours to get the care that they need? They could just get that right from their home, from our specialists at UC Davis Health. So there's a lot of really exciting opportunity around digital kind of transforming the way that we could deliver care in so much more accessible, equitable ways. But a big challenge is that we also need to do this in a very collaborative way. We can't do this alone. We have to work with our communities. We have to work with our patients directly. And we also, being a health system that serves a patient population that really maps the entire diversity of our country's patient population, we need to work very closely with other health systems, other institutions, to be able to say, okay, how do you deliver healthcare? What are the problems that you're seeing? And how do we actually solve that together in a more open innovation manner? And so in our first year of launching the Digital Collab, we also partnered with Amazon Web Services to launch the Cloud Innovation Center. So we were the first academic medical center, first health system to host a Cloud Innovation Center, where this was a true public-private partnership where industry came and said, hey, we need your expertise around the medicine, the clinical operations, and the insights that you have with your patients. And we will bring the expertise of technology and product development. And how do we kind of combine forces to do this, and then make those findings available to everyone? And so everything that we do through our Cloud Innovation Center piece is actually completely open sourced. So there could be startups coming out of UC Davis, out of UC Berkeley, out of University of Wisconsin, that can literally take the work that we do and actually turn it into a startup. Big companies like GE or Philips could take some of these open source innovations and actually turn it into viable products that are sold to their customers. So there's a lot of opportunity for us to really lead through collaboration and open innovation. And I think that's also another area where I'd love to, I encourage this group to think about that. Like, how can we, as a publicly funded institution, be the nexus for collaboration, but also kind of the fountain for information and insights that the entire industry, the entire world can use to accelerate the impact that we can make together. And so that's the Cloud Innovation Center. So I wear two hats, at UC Davis Health. What's amazing with this Cloud Innovation Center is we're also not alone. There's actually 12 other Cloud Innovation Centers around the world that have partnered with Amazon Web Services, and they have very different focus areas. So ASU, Arizona State University, actually focuses on AI. University of British Columbia actually focuses on more wellness. And there's a lot of different themes across these. But again, when you think about climate, we all share the same climate and the impacts coming from climate change. And so we really see this as actually a global network of organizations that are able to solve some of the biggest problems that our society, our whole world is facing. And I think that's also another really great opportunity that I'd like to offer to this group is, how do we really, again, extend that network beyond the walls of UC Davis, and how do we kind of foster that interdisciplinary collaboration? Because I think that's going to be so mission critical to climate and climate health. So going to the core of this presentation, I think a lot of people may already be aware, but just to kind of put it into concrete numbers, healthcare accounts for 13% of global carbon emissions. So this was a think tank called Health Policy Watch that kind of generated this data. And so healthcare really contributes to a pretty big portion of the carbon output. And then that's also just specifically to healthcare facilities. So if you look at, there's also pharmaceuticals that's broken apart separately. So it could really count for 25 to 30% actually of all carbon emissions coming out of various industries. Now, if you double click into healthcare specifically, where is among that 20 to 30%, where is it coming from? Healthcare facilities account for about 40% of the healthcare industry's carbon output. It's very expensive to run a hospital at the grade and precision and rigor that we need to. In fact, to the point where we have on the health system campus our own power plant to ensure that we're providing the continued care that they need, and we're able to provide the resilience and the continuity of power to ensure that our ICUs and our emergency rooms and our operating rooms aren't going to come offline. So I think from that lens, because of the rigor of healthcare, we do need to have a lot of redundancies in place, but that can also contribute a lot to the carbon emissions that come out of healthcare and healthcare facilities. So from the CoLab side, our Digital Health Innovation Hub, we're like, well, what can we do more from the lens of health equity and expanding that access to patients? How do we make it a lot more convenient for patients to access care? And fortunately, that strategy aligns very closely with, again, how do we deliver tomorrow's healthcare today, and how do we ground it in equity? So one of the things that we see as a major opportunity with digital health is to expand and scale that care beyond the four walls of the hospital. With digital, we're able to actually discharge patients 1 or 2 days early from the hospital and actually care for those patients at the home, for the remaining last 1 or 2 length of stay days. And what we're doing is we're partnering with industry in various ways. So on the left, we announced a partnership with Dispatch Health. So this company actually provides not just the cars that you see here, but they have APPs, clinicians, and also the devices and the logistics. So instead of a patient having to come to the ED, they can actually go to the home and take care of the care right at the bedside of that patient's home. So if you think about how these types of new models of care that are digitally enabled, more care at home, can also impact climate, and kind of going back to these slides, how do we kind of reduce some of these percentages, and make it a lot more carbon efficient as a whole health system? One bed in the ED will create so much more, carbon output than the home bed, which is already basically, on, and it's not like that's going to be net positive or net extra on the climate. So we're really trying to look at how can we triage not just our patients, but how do we triage, carbon emissions to reduce it by delivering more and more of the care at home. And ultimately, we see it from that patient-centered lens. It's so much more convenient for patients to be able to receive the care right from their home. It's also a lot more convenient for our physicians to be able to see the patient's data all throughout the week and throughout the month rather than only when they're in the hospital. So there's a lot of, I think, opportunities, and we're just at the tip of the iceberg in terms of how much care is actually being delivered, outside the hospital, and then only using really the hospital for certain care like operations, ICU, and tertiary level care that can really only be delivered, in the very controlled hospital setting. But I think bending the climate curve isn't just about going to thinking about it through carbon emissions. So I think a lot of what the conversations that I've been involved in around climate change, climate health in the context of healthcare is healthcare spends, it uses up a lot of energy, and we have a lot of high, output in terms of carbon emissions. I think that's kind of the V1 of where we should be looking at the impact of climate. And I want to reframe this in terms of actually how should we be thinking about this from a climate health and climate health equity lens? So coming back to this concept that climate is something that we're all affected by universally, but the climates are actually microclimates that you have to be thinking about, and in terms of the impact on patients, their health outcomes, and even the types of management that we need to do based on the region. So like I was saying, I could be in Ithaca, New York, where it's snowing like crazy, and they have all the resources in place to make sure that students can walk to their classes. Go to DC where they don't get snow at that level, and so they don't have the bulldozers or the salt or the other human resources addressed. And I think that's this case also with a lot of the exacerbations in climate that we're seeing. It's not all the same across the country, and it's definitely not the same across the world. And so when we think about California, we have the wildfires. We're starting to get these atmospheric rivers, and that isn't necessarily impacting the entire country. It's actually impacting very specific even parts of the state. And that's like really where I think the best opportunities for collaboration is that beyond carbon emissions, we need to realize that all of our patients across the country, across our state, are going to be impacted very differently. And many of the patients that are going to be impacted disproportionately high are often the ones that are currently underserved and the most vulnerable patient populations. Thinking about the unhoused patient population, right? They don't have shelter. So when it goes to higher extreme temperatures, hot and cold, wildfires, a lot of these are going to disproportionately impact the unhoused patient population or some of the other vulnerable patient populations and underserved patient populations more than the rest of the population. So I think these are really important for us to do more research, and that's in the sense of data and analytics. How can we actually look at various data sets that are non-traditional to be able to factor that into how we proactively manage our patients? Climate is a really great example of a data set that we typically don't use in day-to-day medicine, right? Like it is something that we're aware of as clinicians, but it's not something that's actually factored into the population health strategies in a very real-time manner, right? It's still a lot more reactive, and I think we have a big opportunity to be proactive with that approach. I wanted to just give you some examples of how this looks in disease-specific domains. So with Alzheimer's disease, right, cognitive impairment and dementia has these patient populations are much more affected by extreme weather, especially extreme heat, and their symptoms can be a lot more exacerbated. Mental illness as well is another one where extreme conditions can really spike up some of the symptoms of those conditions. So we need to be really thinking about that, and how can we use weather data to inform, let's say, a psychiatry department, right, or a family medicine department on how they might be able to proactively address these more condition-specific exacerbations due to climate. Asthma and COPD, I think, is probably one of the more intuitive ones when you think about wildfire or pollen during the spring. These are all things that we really can do a lot deeper dive to say, can we create much more of an early warning system, a early management, almost not quite at the level of prevention, but early intervention, before they have to come to the ED or before they have to come to the ICU for some of these the issues. I think there's a ton of opportunity for us to collaborate in an interdisciplinary way to make some of these more kind of models of care that are data-driven possible. And then moving to just kind of, again, examples, and I'll kind of pause and see if there's any questions, but cardiovascular, diabetes, obesity, disability, I just kind of listed, some of the ways that we could be seeing a more disproportionate impact on these specific disease conditions. And this is coming from a report, so I didn't actually write this for full disclosure. But again, there's a lot of really great research coming out in terms of how do we move from carbon emissions to climate health and climate health equity. There's a lot of really great organizations, but one of my favorites is CHIL, Climate Health Innovation Learning Lab. Chetan Sarabu is in the top left. He's the founder. And I think there's starting to be a lot more initiatives led by clinicians and worked and forming interdisciplinary teams to understand some of the more nuances around health equity, health inclusion, and how climate really plays a big role in impacting these types of issues. And so I really hope that this is just the start of productive discussions and ideations across the many different aspects of UC Davis that we're very strong at in terms of leading collaboration, leading innovations, and how we should be reframing this and seeing and stimulating research that could provide a lot of great insights that people around the country could really benefit from. So thank you very much, and I hope we can have a little bit of time for Q&A.
Thanks so much, Kay. This has been a great presentation, and I think really sets the table for those points around how climate change is already here, and we've really got to adapt our healthcare systems and use the innovative tools at hand to address those disparities. So I'm going to have you sit tight before we jump into sort of a group discussion. I want to give Dr. Andrew Hernandez a chance to talk a little bit about his work, which is maybe a little bit more on the climate change emissions mitigation side of the equation with more energy efficiency equipment. And so, Andrew, are you with us? I think I saw you. There you are.
Yep, I'm right here. Awesome.
So I'm going to go ahead and turn it on over to you. Thank you so much for being here today, and I'm looking forward to your talk.
Absolutely. So let's see here. All right, can you see that okay?
Yes.
All right. Okay, so yeah, it's a pleasure to be here. I hope you guys are all having a good morning. Thank you, Belen and Janine, for inviting me. I unfortunately had another meeting about sustainability I wasn't able to cancel, but I'm really fortunate to be here. I believe there's already an introduction, so I want to introduce myself. But really today I wanted to use this open platform to discuss how we might be able to leverage collaborative solutions to reduce greenhouse gas emissions within healthcare. And I really want to use examples of initiatives at UC Davis Health, just kind of small snippets of initiatives, and then focus a little bit more on how we're doing, what kind of initiatives we have specifically in radiology. And so, given that you're at this research forum, I imagine that you already have some idea about greenhouse gas emissions, but I feel it's a good time to kind of provide a little bit of background on this. And so this is a nice picture that I like to use in some of these discussions. So the atmosphere surrounding the Earth is composed of nitrogen, oxygen, argon, and trace amounts of other gases. And there's actually naturally occurring greenhouse gases. And so the natural composition allows for shortwave radiation or the sun's radiation to essentially transmit through the atmosphere and warm the earth. And so that's, of course, while in the middle of the day, we have a warm earth. But then at night, of course, what happens is infrared radiation or long wave radiation, in other words, heat, that allows for us to cool the earth at night. However, there's many sources of non-natural or man-made greenhouse gases, and those are essentially emitted in the atmosphere. And what happens is those greenhouse gases actually trap the infrared radiation or the heat that's emit from the earth. And so that results essentially in global warming. And so there's a bunch of sources of these greenhouse gas emissions, and I want to touch a little bit more on what types of emissions we have specifically from healthcare. And so the U.S. healthcare system accounts for about 8.5% of the U.S. greenhouse gas emissions as of 2018. Actually, if we were our own country, so if the U.S. healthcare system was its own country, it would be the 5th leading greenhouse gas polluter, essentially, of the entire world. So that's pretty crazy to think that just our healthcare system would be the 5th largest polluter. And if we let me minimize one of these over here. Okay. So if we look essentially at if we try to categorize essentially greenhouse gas emissions based upon different scopes, and this is how they use to kind of talk about the different sources of greenhouse gas emissions. So on the left here, we have scope 1 emissions. These are directly from the operation of healthcare facilities. Scope 2 is indirectly from purchase sources. For example, electricity we purchase from SMUD. And then scope 3 is actually from the supply chain of healthcare services as goods. And so if we actually look at the distribution of the different scopes for healthcare, over 70% actually come from scope 3 emissions. Recently, there was actually a Senate bill in late 2023 that requires that profit companies in California making more than $1 billion in revenue by 2025, they'll actually have to report their emissions. So this is awesome. I'm really glad that this Senate bill passed. UC Davis is, of course, a nonprofit organization. We have much more than $1 billion annual revenue. But fortunately, a lot of the companies that we do work with, a lot of the companies that we do get some of our goods from, they are in California. And so they'll actually be required to report emissions. So we might be able to tailor our purchasing or procurement to those companies who have the least amount of emissions. And so as Kay brought up earlier, there's really a very strong connection between human health and the environment. There's countless examples showing strong health effects of climate change. Those can be related to elevated temperatures, air pollution, weather-related catastrophic events, and really mental health related to just the stress about climate change. There was an excellent review article by Maura Brown and many others, which was published in Radiology last year. And really, it's my opinion and the opinion of many others that hospitals really play a strong role in reaching the communities they serve. So I'm sure many of you are well aware, UC Davis Health serves a large community in Northern California. And so reducing emissions and waste, as well as advancing sustainability, will really have a healthy impact. This figure on the right was from a talk I saw at RSNA this year, and I think it really draws some nice kind of lateral thinking, where healthy hospitals creating healthy planets and creating healthy people. We're all interconnected, and it's important to really try to tackle this, not only for just reducing greenhouse gas emissions, but as Kay brought up, for health equity as well. And so one example of that, there's actually this really interesting article. Never read this journal, but this was actually shared with me. Science Advances. This was published in February 2023. Some researchers from, I think, UCSD and UCLA. And essentially what they wanted to do is they wanted to explore the synergistic effects of compound climate hazards. So extreme heat and wildfire smoke. Obviously, those are super prevalent here in California, and how those really relate to cardiorespiratory hospitalizations. And so normally I don't write a big old conclusion sentence, but damn near every single sentence, every single word in this quote is important. So communities with lower education, lower health, lower income, lower proportion of auto insurance, lower tree canopy coverage, higher population density, higher proportions of racial and ethnic minority, they experience higher synergistic effects, meaning that they are affected both by extreme heat and wildfire, and it causes severe cardiorespiratory hospitalizations. And so really climate change is and will continue to unequally affect communities which are suffering the most from health inequality. And unfortunately, the worst is really yet to come. This provides really much needed evidence to aid decisions like clean air and cooling centers, as well as targeting educational campaigns for individuals in some of these communities. So I'm not going to lie here. A lot of the work that we're doing are small drops in big buckets. And so what I mean by that is, if UC Davis were to say be a net zero community, that's not to say that all these issues that we're seeing are going to be solved by any means. But if all healthcare systems and all businesses across the world did, this would absolutely affect. And so I'm really hopeful for a better, more sustainable future if we all work to get together and are not just independently working on these things in small areas. And so how can we do better in healthcare? So scope 3 emissions, for example, one of the biggest things that we can do at UC Davis is actually procure reusable goods. One example I'll talk about today is reusable isolation gowns, shown on the right-hand side there. In addition, to reduce scope 1 emissions, we can, for example, decrease our waste in anesthetic gases. So I'll give some examples of how that was done in the anesthesiology department here at UC Davis Health. And then specifically in radiology, we wanted to look at how we might be able to come up with more energy efficient medical imaging equipment. And that will, of course, decrease scope 1 and scope 2 emissions because we actually have on-site energy. So we have a cogen plant that burns natural gas, emits greenhouse gas emissions, and we also get our energy from SMUD. So we kind of have scope 1 and scope 2 emissions in terms of energy consumption for medical imaging equipment. So again, lots of very interesting initiatives that are happening here at UC Davis, and I'm just selecting a few from some of my colleagues that I've worked with here and in the past. So first, I'm going to talk about anesthetic gases. This is really some work that was spearheaded by Nina Schlomer-Kemper, who's a professor of anesthesiology and pain medicine. So I talked earlier about how greenhouse gas emissions are emitted in the atmosphere, and that causes absorption of the heat that's emitted from the earth. But anesthetic gases actually have a much higher global warming potential than CO2. So per unit, per parts per million, anesthetic gases are absorb much more heat than does, say, for example, carbon dioxide. So at UC Davis, nitrous oxide was piped from a central location. So we had, these large canisters, and essentially 97% of the nitrous oxide was leaking. So I'm just going to repeat that one more time. 97% of the nitrous oxide that was coming from the canisters was actually just leaking. And so essentially what they did is they decommissioned these centralized, where's my mouse here? They decommissioned, let me put a laser pointer. So on the right-hand side here, this is showing these canisters actually sitting bedside now instead of a centralized location. So here's showing these canisters are actually now capped. That's kind of what the image here is trying to show. And so now 100% of anesthesia machines and 100% of the operating rooms have migrated to local canisters. And in addition, we have a 30% reduction in nitrous oxide usage in the last fiscal year compared to 21-22. In addition to the leaking nitrous oxide, anesthetic gases in general, patients only metabolize 5%. So the rest is actually exhaled into the atmosphere. And in a particular note, one of these anesthetic gases, desiflurane, is much, much more potent than similar anesthetic gases that have similar clinical efficacy. So we actually, the anesthesiology department actually banned desiflurane. They worked to improve education of flow rates, and they developed this monitoring interface where they can actually provide dashboards to the physicians and the technologists to try to minimize the usage of anesthetic gases, to try to minimize the greenhouse gas emissions directly from anesthesia. And so this is really a collaborative solution. Tons of individuals all across the UC Davis health system helped make this a possibility. And so they reduced a 30% reduction in nitrous oxide, only canisters, and implementation of AIMS. And so this is equivalent to about 120,000 miles driven a month by a gasoline-powered vehicle. And so in addition, there's some work that's done in the emergency department, reusable gowns, reducing waste. This is done by David Barnes. And essentially what they did is they replaced the single-use plastics with textile-based gowns. So this is significant reductions in energy, reduction in greenhouse gas emission, reduction in water consumption, and almost nearly eliminating solid waste. And in addition, these actually have end-of-life pre-processing. So essentially what they can do is they turn these into rags once they're at the end of their life. And currently there's about a 90% adoption. decision, and kind of analogous to the previous decision, huge collaboration, really a successful implementation in the emergency department, pretty substantial cost savings, and of course, a positive environmental impact. You know, arguably some of the biggest issues that we have in terms of our emissions is really waste reduction. And so the UC Davis actually committed to decreasing our waste to 25 pounds per adjusted patient day. So that's about the average. So what that, that metric is essentially kind of a normalized metric to normalize by a single patient day. And so this is a UCOP Clinical Enterprise Management Recognition Plan, or CMRP goal. And this is just a random snapshot that I took out in the loading dock in the south end of the ambulatory care center. So there has been some great initiatives. Over the last several years, we've seen really a monotonic decrease in the waste generated per patient day, sitting at about 33 pounds per adjusted patient day. If we compare ourselves to some of the other UCs, we can see that we have a lot of work to do. We have about 7 pounds per adjusted patient day to go if we want to reach this goal of meeting 25 pounds per adjusted patient day. So some of the initiatives that exist here is we actually develop a relationship with Stryker, and they actually do some reprocessing of single-use devices. So essentially, there's kind of collection zones, and those are collected, and then Stryker reprocesses those, and ultimately, hopefully, are diverting those from the landfill. In addition, in the IR, so in interventional radiology, where we do some kind of image-guided procedures, we're going to fully reusable instruments, as shown in the top right. And several years ago, the paracentesis clinic. So paracentesis is this process whereby you're removing fluid from the peritoneal cavity. And a lot of the times, essentially, what happens is they fill up these large jugs of that fluid, and then those are just put into to waste. Some patients will actually have like 8 to 10 of these relatively large bottles. And so there's this device called a streamway system, where essentially they remove this tube, it goes through this filter, and then it just goes straight into the drain. And so it allows for us to divert a good amount of the waste from those bottles, divert all this waste from the landfill. There still is some associated waste, so there are filters, and there's also cleaning solution. So we're doing some work to really try to pinpoint if this is actually more sustainable, and really what the reduction in waste and greenhouse gas emissions are related to this device that we now employ in most of our paracentesis clinics. And then lastly, I'm going to touch and speak a little bit more of some of the work that we're specifically working on in radiology related to energy efficiency in medical imaging. And so there's some excellent work that's done by Cassandra Thiel, who's really a leader in life cycle analysis and healthcare, in collaboration with Vanderbilt. So essentially what they did is they looked at a 10-year life cycle analysis of a radiology department. Not really enough time to talk in detail about life cycle analysis, but it's really, as the name says, you look at the whole life cycle of device, all the way from the procurement of the raw materials, the transportation, the production, and then the utilization, and then what happens after that device is no longer in use. And so really a loaded plot. I'm not going to sit here and explain all the nuances related to this, but really what I wanted to draw your attention to is 2 main facts. One is that the greenhouse gas emissions from MR suites are the highest, is really the highest emitter, and compared to CT, X-ray, and then ultrasound. And in particular, the largest proportion of the greenhouse gas come from the energy use, so the energy that's required to actually operate these scanners. And so if we dive a little bit more into that, this is a plot from the Canadian Coalition for Green Health. And this is essentially the average unit energy consumption per year shown for MRI, CT, X-ray, and ultrasound. So we see the MRI is nearly 3 times higher than CT, which is nearly 10 times higher than X-ray, and then ultrasound is substantially lower. So clearly, if we want to start looking at improving energy consumption of one modality, it would be good to start with MRI scanners. And I see that we are getting to the last of the time, so I'm going to kind of brush through these a little bit quicker to leave times for questions. Again, collaborative solutions. The idea here is to gather energy consumption and look at energy efficiency improvements for MRI scanners. We work specifically with the Energy Star, so they're developing specifications for medical imaging equipment. And essentially what we did is we provided data to test the draft method that they are going to employ for vendors to use when they're quantifying energy consumption. And so we developed metering for these systems. And here's an example of some of the metering that we did. So on the plot here, we see power on the y-axis, time on the x-axis, and we can see that one of these pulses, so this pulse sequence here, allows for us to reconstruct a three-dimensional image. And so there's three important kind of characteristics. We have ready to scan mode, which is energy consumption between pulse sequences and immediately after pulse sequences. We then have low power mode and the off mode, where the off mode is where the technologist actually physically turns the scanner off. But you can see there's still a finite, a DC amount of energy consumption, and that's related to a constant energy required to operate the cold head compressor, which essentially allows for us to operate the superconducting magnets that we use to generate images in MRI. So we acquired data, we shared it with Energy Star. They developed the first draft method, the first draft of their specifications, and this requires automatic shutdown after 30 minutes and requires that low power mode consumes no more than 80% of the energy in ready to scan mode. We also looked a little bit more closely. So we looked at a specific scanner. We said, okay, which one of our protocols actually has the most amount of energy consumption? So this is during active scanning. We found the MRI by far, or not by far, MRI of the brain had the highest energy consumption for this particular scanner. In addition, one thing that we looked at is the time to low power mode. So immediately after a scan, how long does it take for the scanner to go into low power mode? We found that there actually wasn't kind of a single value for this, and it really changed depending upon the protocol. So we wanted to simulate what would happen if all of the scans actually went to low power mode after 10 minutes. And we found that nationally, if all scanners went to that, it would amount to 5,700 gasoline power vehicles driven for 1 year. So that's saving that much emissions just from this one concept of it going to low power mode after 10 minutes. We also did phantom experiments. So as a medical physicist, we do a lot of phantom experiments, nice chunks of plastic, well, really expensive chunks of plastic that have these different features that allow for us to understand image quality. And so modern MRI systems have deep learning reconstruction. So it's a way that we can acquire shorter scan times to get similar image quality. So we did that. We tried to look at the differences in energy consumption related to scan time and different reconstruction algorithms. And essentially what we found, again, because of time, I'll brush through these. Deep learning reconstruction with the medium strength provides comparable image quality quantified by SNR and low contrast detectability with a 65% reduction in energy consumption. So our highest energy consuming protocol on MRI, we can actually reduce the energy consumption during active scanning by 65% just by using some of the more advanced features on those machines. And then lastly, in conclusion, I really think that addressing climate change demands collaborative solutions and creation of creative solutions, really. At UC Davis, unfortunately, a lot of our initiatives mostly stem from grassroots efforts rooted in collaboration and driven by healthcare professionals. And these have yielded some results, but I really think that we need a lot more momentum. We really need enterprise level engagement and commitment, and this is pivotal for driving these changes. So of course, we expect kind of a linear increase in climate action as we knew about climate change quite some time ago, but I really think that we're at this area where we're seeing this huge exponential increase in action towards climate change. Happy to be here. I wish we would have started earlier, and thanks a lot for your time today, and open for any questions.
Wonderful. Thank you so much, Andrew. So we can go out of screen share here, and I encourage people to go into gallery mode and turn on cameras. I know we've got about 4 or 5 more minutes. Luckily, our speakers did provide some contact info on the slides, and we can send out that contact info in the follow-up email as well. But Ana Lucia, is there a way that we usually do sort of moderation of this last bit?
So I see already Amir has his hand up. So Amir, if you can briefly state your question. I think he's joining us from BASF.
Yes, hi, can you hear me?
Yes.
Yes, thank you so much for this seminar and presentation. Me coming from the company, from the industry side, the question is, how can we help you guys to reach your goals? So my question would be, for example, to Kay, on his slide that you showed, pathway to net zero. How can BASF address that huge blue chunk on that graph where the big chunk is on the medicine and purchasing and the supply chain. How can industry help with that?
Sure, great. Thank you for that great question. I think again, you can't just address one part of the supply chain without really looking at it from a holistic lens. And I think that's where, I think we really can't do this alone. Some of the analysis that, Dr. Hernandez shared, we need to really look at this from what parts at each point of the supply chain can we address? And then how do we do this from an end-to-end formula to understand the net reductions? So I do think that we need industry at the table, absolutely. And I also think that we need to have health systems and academia collaborating very closely to come up with that right formula.
If I could ask
Thank
a
you.
follow-up question, sorry, what's BASF? What industry are you from?
So BASF is a chemical company, and we make the chemicals for everybody else. For example, if you use Thermo Fisher for your tubes, we make ingredients that we sell to Thermo Fisher to make your plastic tubes. If you need IV and you buy that, I don't know from where, for Qiagen, Corning, or I don't know from who you buy it, we provide ingredients for these big companies to build your IV line, your syringes, your gowns, whatever. We make like ingredients, chemicals, polymers, and small molecules to kind of build that. So that's where we come.
Yeah, so
Thank you, Amir. Oh,
So-
sorry.
yeah, I was just gonna say, Amir, I mean, I think that you're at the driver's seat, right?
Yes.
The materials that you're using are being used for a number of different applications that we use here in the
Exactly.
health system. And so I mean, it's almost like you just need to come up with the most try to minimize your emissions when you're producing those chemicals. That's essentially where it's going to start from. And then a lot of companies, it's a big field right now, life cycle analysis. We're working with vendors to try to develop life cycle analysis. And so if you can provide data for, say, Thermo Fisher, if they want to do life cycle analysis, and you can understand that would be an area where I think would be really helpful, because I do think that we need to understand where the most amount of emissions are come from, so that we can begin to mitigate those.
I agree.
This goes also, just quick comment on, I think successful projects have a very clear goal and success metric that you can measure, right? And because each of these efforts do require a non-zero amount of investment from each portion of the supply chain. So it's not, how do we actually come up with a unified metric, right, that allows us to then be a lot more precise with what types of net reduction investments we make to achieve that collective, metric together. So I think that's also a really key part of that process.
I agree.
Other questions from our audience? I have a question. So Andrew, you mentioned that a lot of the activity that's been going on is grassroots. Is there a process, like if someone at the School of Medicine has an idea of like, hey, I work on this and I have a thought of something we could change on where do they go? How does that, where do people go to kind of pitch their ideas, or how does that happen?
Yeah, it's an excellent question. So I was trying to, unfortunately, I didn't have quite enough time, and I apologize for that. Or maybe there are some things I could have talked less about. A lot of the stuff that we've done are really grassroots. I got involved in sustainability with Bill Pevick, who used to be the chair, I think the chair of vascular surgery. Now he's an emeritus professor, retired, and his retired duties hopefully stays longer, but he's actually really helping support getting everyone together. He started UC Davis Health, what do we call it, Sustainability Advocates Group, and essentially that's an area where a lot of people come together from a lot of different facets: procurement, physicians, nurses, staff members, physicists, kind of the smorgasbord of different people. And that's a good area, because I tried to draw this, but there's so many different people you have to talk to just to make a difference. And so joining that group, whoever those people are, if you give them my email, or they can email me and I can help try to connect them. Unfortunately, so UC Davis, we have one person who's paid to do sustainability. That's Christina Cullen. She's the director of sustainability. One of the things that we're really trying to develop is we're trying to bake sustainability into job descriptions. A lot of the times what we get, unfortunately, try to ask people, hey, could you help me with this? Can you help me with that? It's not a part of my job description. Well, if we make it a part of their job description, then it's going to be part of their duties and they're going to feel motivated to do it. And so hopefully we're going to see a paradigm shift where it becomes a part of people's job descriptions. And then there will actually be resources and people's staff to help facilitate these projects. There is, I can't remember the name of the group, but there is a group that essentially there's like an area where you can send in your ideas about sustainability, and they can mainly related to waste reduction, and they can help you try to come up with ways that you can procure more reusable instruments. So sorry, that wasn't a very strong
No,
answer.
that's good. It's like, yeah.
There isn't an easy solution, unfortunately.
More questions or comments from our audience?
Just a proposal. I know there's a group, Hack Davis, maybe involving students in some ways to come up with an app or one of these systems for doing intake of ideas, and I don't know, have student fellows or other fellows to kind of execute on such projects, maybe 6 months or one year, something like that.
Yeah, I think Belen was telling me about is that the same thing, the climate hack, or I can't remember, Belen, what the name of it was, but Aggie Square, I think, is going to have a class where largely students can come and do that. Belen, I don't know if you could elaborate on that for us.
Yeah, I think you're referring to a Hacking for Climate course.
Yes, that's it.
Yeah, not through Aggie Square, but just as a formal course on campus that will occur in the fall.
Yeah, so if people have ideas or initiatives, Andrew, send them to Belen, and we can see if we can put a student group on that kind of idea of like, what would it look like to deploy that?
Be careful what you wish for.
Well, let's at least start the conversation.
No, I'm just.
Yeah, that sounds great.
Awesome. Nothing's better than getting younger people who are earlier on in their career. I mean, there is so much opportunity for this to really develop a whole career associated with that, and it really spans all departments.
Okay, we have time for maybe one more. Irva. Irva has her hand up. I think you're muted, Irva. Oh,
all of a sudden, my phone decided I was in my car and muted me. So I just wanted to ask about the equity aspect of this, and what do you see as actual concrete mechanisms so that the benefits would go disproportionately to the communities that are already disproportionately affected by climate change, in sort of the model that you're putting forward for innovation and reduction of greenhouse gas emissions?
I'm not going to pretend like I'm an expert in climate equity. I'm a trained medical physicist. I got my degree in biomedical engineering. I want more than anything for this to be equitable. Unfortunately, I don't have the best answer for that. But what I can say is that every effort we can make to reduce greenhouse gas emissions will ultimately improve the life of some of these areas, as I pointed out in one of my third slides, that are they have the compound hazards of wildfire smoke and extreme heat, right? If we reduce the greenhouse gas emissions, the levels of those are going to decrease across these communities. So I hope others have a better answer related to climate equity.
Well, I would suggest bringing engaging with some community organizations as you are working through these various solutions, which, you know, it may be that the hospitals in rural areas where a lot of the extreme heat effects are most exaggerated, you know, will be the last to be taking up some of those measures, and maybe those kinds of collaborations could be built by you know, working with some of the some groups that are interested in this and are in some of these environmental justice communities in the Central Valley in California in particular. That might be a way, and I know there are various offices on campus. Our Environmental Health Sciences Center has a large community engagement component to our work, and can help you know, maybe connect with some of these efforts.
Thank you, Irma.
I'll
Last question, Tamar.
Yeah, no, thanks for running this event, and thanks to Kay and Andrew for giving like a good, especially like the details on like MRI energy usage and whatnot. That's really awesome. Yeah, I was just wondering, given like the rise of, because I mean, this is something that I look at a lot in working in quantum computing, where quantum is said to like maybe decrease the total amount of energy usages for high performance compute. I was just wondering what if that was something that was looked into in terms of the compute loads of the medical center, and like how much energy that's using at all.
Yeah.
If that's something that's impactful, especially given the idea of using more AI and doing more like machine learning, which would just, you know, increase the amount of compute needed.
Yeah, lots of things to discuss. So I saw the World Economic Forum. Man, so many acronyms. Yeah, the World Economic Forum said that 2.5% of global emissions come from data centers, which is actually more than the aviation. Aviation is like 2.1%. So hit the nail on the head. Computing resources, data centers, which is of course the internet, is a huge polluter essentially. So it's kind of now talking a little bit specifically about healthcare. Again, I didn't have time to dive into the details. I showed those life cycle analysis. I talked about how energy consumption was the predominant one. Actually, the second one was the PAC system, Picture Archive Communication Services, essentially where all the medical images for all the hospitals at UC Davis, it's all put in this one repository. That's called the PAC system. So that's a huge greenhouse gas emitter from all the energy consumption for that. And so that's another area I hope in the near future we can actually meter that and see if we can't come up with more efficient, maybe servers. Maybe there's ways so that we could store images that they don't have to be backed up necessarily. And then specifically about deep learning. So we actually have done some preliminary work where we're comparing in our department in our division of medical physics, we do a lot of machine learning. We're comparing analytical approaches with machine learning approaches. For example, parametric mapping in MRI. So that's where you essentially figure out cerebral blood flow. So the blood flow in the brain, and you can, on a pixel level, determine blood flow in the brain. And so we actually found that if you're just doing a few patients, like 5 patients, analytical approaches is a little bit more energy efficient than is machine learning. But once you get to 10 cases, the training of the machine learning algorithm, that takes a substantial amount of energy. But then you're just applying weights. And so once you're just applying those weights to the machine learning algorithms, it's actually much, much more efficient. It's like a factor of 5 more efficient than using an analytical approach. So, I think there's a lot of area for exploration to try to understand, I actually think that maybe artificial intelligence might allow for us to have more efficiency because we're no longer working on these advanced computational. We're training networks, we're applying those networks, and I think it'll actually be more efficient. And so very much unknown. I don't know anything really about quantum computing, so I'm not even going to pretend to try to answer that question. But I would love to talk about this more. And if you work in quantum computing, that's an excellent area to begin exploring more sustainable approaches and comparing those to conventional approaches.
Thank you.
Of course.
I think we are out of time. Maybe not out of questions, but we're out of time. We're at almost 15 minutes over. This was a very interesting conversation. Definitely a lot of information to follow up on. I invite everyone to please reach out to Janine and Belen if you have questions about the ACE program within Venture Catalyst, and to reach out to our speakers if you are interested in figuring out ways to collaborate with them or pitch ideas. And our team at Office of Research is always available to help you make connections. So please don't hesitate to reach out to me or anyone in my team. Have a wonderful weekend, and we'll see you, I think, in 2 weeks when we're going to talk about metabolic health. So I hope to see some of you back here on March 22nd. Thank you.
Thank you, everyone. Have a good rest of your day.